Good afternoon, and a very warm welcome to today's episode of our talk show series, Let's Talk Primary Healthcare. Last June, we had a thought-provoking discussion with young professionals who chose to work in primary healthcare. They were from 4 countries, Malta, Romania, Kyrgyzstan, and Denmark, and there were interesting similarities across their experiences. They shared with us their inspirations. They shared with us their challenges. They shared with us their thoughts about their training and their thoughts about how to strengthen and innovate in a primary healthcare setting. Today, I will ask our panelists to reflect on the thoughts of our young colleagues and to begin to search for answers together. And for that, we have a great panel, and I'm very excited to welcome them and introduce. With me in the studio is Dr. Natasha Azopardi-Muscat, Director of Country Health Policies and Systems in the WHO Regional Office for Europe. Dr. Tomas Zapata is Regional Advisor on Health Workforce and Service Delivery, also in the Regional Office for Europe of WHO. And online, I am joined by Dr. Virpi Sulosari, Principal Lecturer of the Faculty of Health and Welfare at Turku University of Applied Sciences from Finland, and she's also President-elect of the European Oncology and Nursing Society. And Dr. Antonia Poplas-Susic is the Director of Community Health Center in Ljubljana in Slovenia. A big warm welcome. Thank you for taking the time and join us. And we're going to jump into our discussion right away, and I'm inviting you to watch a 2-minute video together to remind ourselves some of the key points of our young health professionals.
Hello, my name is Stephanie. I am a primary healthcare nurse in Denmark. I chose to work in primary healthcare as a nurse because of the complexity. It is a dynamic and complex setting. I can assess health problems of people more holistically in their context, their family, home, workplace, and community.
My name is Shirin, and I'm a young family doctor from Kyrgyz Republic. And I become a family doctor because I do not just want to address isolated diagnoses and episodes of illness. I want to address root of complex health problems over longer periods of time as a part of a broad team to approach health problems comprehensively.
Hi, I am Katja Sakko, a pharmacist serving a community in Malta. I work as a community pharmacist because the potential of building trust in the community we serve is so meaningful, and people need and value our guidance.
I really worry about the prestige of primary healthcare. It is often seen as a place for early retirement. We are very driven and well-trained professionals making a difference. We are trusted by the people and helping them avoid complications and preventing unnecessary hospitalizations. We need to talk more and better about what primary healthcare is and how it makes an impact for the individual, the community, and the society.
My personal hope is and wish is to increase the prestige of family medicine. This will help attract young graduates to this beautiful and very important profession. For that, we need government action, local action, peer-to-peer support, WHO support, and each of us can do something.
Let's start our first round of discussion, reflecting on this video. And both Stephanie and Shirin mentioned the word prestige. This is what I'd like to focus on in this first round. And Shirin had a very powerful ask. To enhance the prestige of primary healthcare, we can all do something. What is it we can do? I ask the panel to reflect on this question from their different vantage points. And I'd like to come to you, Natasha, for a regional perspective. What are your thoughts on this video from a regional perspective? We are in a pandemic or post-pandemic context. We have a war on the territory of our region affecting millions of people and many countries. how do we see the role of primary healthcare evolve in the future, and how can we enhance the prestige of primary healthcare?
Thank you very much, Melita. And let me first start by saying how exciting it is to be here in Almaty, the birthplace in 1978 of primary healthcare, in this talk show today. And of course, primary healthcare has been on the agenda. So for example, in 2018, we had this important conference in Astana that once again reaffirmed the values and importance of primary healthcare, but also highlighted the gap between the vision that was established in 1978 and what was actually happening in reality on the ground. You rightly alluded to the difficulties that primary healthcare has had to face over the past years. And indeed, what I say at the moment is that primary healthcare is experiencing a crisis on top of a crisis. How do we see it at the European region? With the important work that you and your team had done, last September we launched a visionary paper that sees that primary healthcare goes beyond just ensuring universal health coverage, quality healthcare for people where and when they need it. But primary healthcare is also important for people in times of health emergencies. And we know from the COVID pandemic that here primary healthcare, particularly at the beginning of the pandemic, was not well equipped. And all discussions now that focus on preparedness and how we do better are clear that primary healthcare needs to be part of the solution. But finally, and I think this is really important, looking forward, primary healthcare has such an important role to play in improving the health and well-being of our populations. So coming to the prestige, I mean, clearly primary healthcare has this fundamental role to play, and the young professionals who are joining primary healthcare get this vision. They get the importance of their role. We heard from the video. But far too often we see at the moment even that as countries seek to invest after the pandemic in their health systems, not enough attention is being given to investment in primary healthcare. We need to have the quality infrastructure. We need to have the access to the digital health systems. And we need to ensure that our health workforce is seen to be and is at the same level as the workforce working in hospitals. Unless we get these basic ingredients right, such that the people who work in primary healthcare can feel that they are recognized, and the people, the patients who step into primary healthcare facilities feel that they are really stepping into a place that delivers high quality health services, we won't be able to really close this gap on prestige, I'm afraid.
Yeah, I think that's a very important point, and I agree with that, that the basics have to come first, and I'm sure some of our speakers will pick up that point. Let us now go right away to the voice of practice. Antonia, let's hear from you. You're managing a community health center with a very large multidisciplinary team, and I am considering myself so fortunate to have had the chance to visit your center. Where do you see opportunities to enhance the prestige of primary healthcare? And what can facility managers like yourself and others do to attract young professionals to primary healthcare?
Thank you very much. It's an honor for me to be a part of this talk also. We know that primary care solves more than 80% of health problems, and with the advanced facility we can do more and better. So we have equipped the teams with modern diagnostic tools such as bedside ultrasound, ECG sensors, spirometer, ankle brachial index meter. We are piloting telemedicine, and in the field of rehabilitation, we have invested a lot in physiotherapeutic equipment for faster recovery. In the area of prevention, patients can experience what would happen in case of obesity, smoking, or high blood sugar with simulation. We are now in the process of modernizing the outpatient information system because the administration and paperwork are very burdensome. Community Health Center has established also a research and development department and equipped it in a very modern way, creating the first simulation center at the primary level in this part of Europe to teach, strengthen skills, improve quality, and to do scientific work which must be a part of primary care. As the number of team members is increasing a lot, we need a lot of new space, so we have brought professionals together with architects to plan a new building where we determine how the rooms should be arranged to allow intensive teamwork. But the prestige is ensured by young colleagues who promote our activity. So we had an open day for students, and next week we have a presentation at the Career Congress for Students, where our young colleagues will present how we offer teamwork, train communication skill, our research project, and the use of new technology in teamwork.
So I hear a lot of important words there: teamwork, complexity, investing in technology, variation or varied work setting. Those sound very interesting. Let me just stay with you for another moment, shortly come back. You mentioned the issue of paperwork. And I think we are nodding vehemently in this studio, and I think our listeners are also nodding. We see in many countries that there are great opportunities to further digitalize simple processes and complex processes as well. And we know that these are so important for young people who grow up in the digital age. I think they look at some of our paper-based processes and they really smirk or smile. Any good experiences from your center where you use this approach of enhanced digitalization to attract young health workers?
Yeah, thank you. Actually now, together with the provider IT, young doctors have started to develop a portal for patients. It allows patients to communicate text, attach documents directly to their medical records. They can also order medication from the list of permanent therapy, medical devices, referrals, and sick notes by only ticking off what they need. The doctor can only confirm the scope of messages and the number of attached documents is regulated, and the settings is determined by each team. It saves a lot of time. The work is done in a safe environment. Patients become more aware as they learn the names of their medication and see when they expire. We are the first in primary care in Slovenia to digitize this communication with patients, and we did it on the initiative of young employees. The medical teams are excited and the patients are happy.
I like that example very much, and this morning we were in a health facility here in Almaty where also some new initiative and innovations were presented by an advanced nurse, and these new initiatives were his own initiatives. And what he mentioned as an important factor is that the leadership and the management of the center, right, gave him the space to run with these new initiatives. So that's very important for facility managers, I think, to recognize these initiatives, give the space for it, adopt it, and then present them for future potential rollout. That example spoke to me very, very much. Virpi, let's come to you now and to Finland, and you have a unique vantage point sitting in a university setting where you have the chance to actually shape the education of our future health professionals. What are your views on this issue of prestige, how to enhance it, and what can we do specifically at the stage of education already to do so?
Thank you so much, and thank you for inviting me to this important event. I think in general it is very important to acknowledge how important position primary healthcare professionals have in the healthcare system and in the overall care continuum. So for example, in care continuum of people affected by cancer, it starts from prevention, early detection and care during the whole cancer care trajectory to survivorship and palliative care. And primary care really focuses on the whole person care and address those health behaviors as well as support adherence to care. And therefore, for instance, in the cancer care continuum, we need primary healthcare professionals in all the phases of this care continuum and care across the different levels of care. And this requires actually really comprehensive education and versatile competencies from primary healthcare professionals. And this is something which I think we need to be more aware and really value and respect it. In today's complex primary healthcare environments, I would also like to highlight that effective interprofessional teamwork enhances the quality and safety of safe provision of care and health outcomes for patients. But it is also a significant factor for each individual of the interprofessional primary care team. And in my opinion, enhancing the prestige of primary health care as a work environment can only be accomplished if the workforce receives recognition and respect by the public, politicians, and also those specialist colleagues and experienced colleagues with whom they work, not forgetting access to further education and these career opportunities through this education towards, for example, leadership, education, research, but also progress in their clinical career, for instance, advanced practice. And leadership is one of the key elements to enhance the prestige as it is associated with motivation and intention to stay at work. And therefore the strong primary care can only take place if there is the facilities, there is the education opportunities, the working conditions are met, and investments on creating those healthy work environments done. And we have increased collaboration among the healthcare professionals from different care settings, and also investing on developing this interprofessional collaboration and practice. And not to forget as a methods, peer support and mentoring. And the last thing I would like to mention as maybe a concrete approach is that we really need to increase the visibility and positive image of primary healthcare as a great place to work and to begin your studies from the undergraduate to later specialized in this important field of healthcare.
Your points very much emphasize similar issues as Natasha raised, right? Some of the basics about the facility, about the training, but also what Antonia mentioned about multidisciplinary or interprofessional teams that actually make primary healthcare a very exciting and interesting place to work. We will come back to this question from different angles a little bit later. Let me now turn to you, Thomas, because you have an overview of our European region, which is so diverse, right? 53 member states we talk about, they're very different from each other. But interestingly, prestige is an issue that matters in every single country. In every country we hear we must raise the prestige of primary healthcare. From the perspective of health workforce policies, what can we do? What are WHO's recommendations? What is our top 3 or top 5 in this area? What can policymakers do?
Thank you so much, Melita. I think it's a privilege to be here in Almaty, as Natasha mentioned before, reflecting on primary healthcare prestige. So, from my point of view, the key to enhance the prestige of primary healthcare is that primary healthcare is able to respond to people's health needs by providing a wide range of quality health services so that they feel that the health problems have been addressed and that they are really looking forward to seek services in primary healthcare facilities or at home, but in primary healthcare. So it's building that trust with patients and with population that I think really brings the prestige. So in other words, I think it's about improve resolutive capacity of primary healthcare to build that trust. And in order to do that, we need policies to increase investment in primary healthcare, to have the right number of primary healthcare workers, the right skill mix, having the right teams of primary healthcare with the right competencies, the right infrastructure, the right equipment, the right technology, and also medicines. So all this enables to provide these quality services. And then I would also like to mention something that I think is a key feature, a key characteristic of primary health care, which is continuity of care, and specifically longitudinal continuity of care. What does this mean in very simple language? That the same healthcare provider follows up the same patient, the same individual over time. And what we have seen is that by having all these soft skills, all this soft information about the patient, his context or her context, and the family, brings a lot of added value and quality in the services and helps in enhancing the quality. There has been very quickly a very good paper published 2 months ago in the British Journal of General Practice, where they look at the entire population of Norway, 5.5 million, 4.5 million population, and they looked, and what they saw basically is that those patients that were longer with their GP provider had less admissions in the hospital and lower mortality. So critical to have this continuity of care in primary health care.
It looks like we have great alignment at the end of this first round. Some of the important points that came out, how to enhance the prestige of primary healthcare. First, it's very important to have leadership, to make the case that primary healthcare matters, to put it in the center of our development policies at national, regional, and local levels. But more than that, I think our panelists are most aligned that talking is not enough, because we have been talking a lot, right, about primary healthcare. We must invest in primary healthcare. We first must make sure that we cover the basics. We must invest in good quality facilities, good education, good training, good instruments, and salaries and working conditions on par with other professions to reflect the importance of this profession as well as its its increasing complexity. And when we enhance quality of care, I think people know a good thing when they see it. If we're able to enhance quality of care, people will go and turn to primary healthcare, and we will not need to justify the prestige of primary healthcare because it will have the prestige. And finally, we touched already on the changing nature of work in primary healthcare, which is becoming increasingly complex with interdisciplinary approaches and teams, which in itself is attractive. And this is what I'd like to consider in our second round, is an inspiring work environment is very important to attract young health professionals. So let's transition to this round. And Virpi, I'd like to come back to you and Finland. What has been the experience of your country to improve organizational culture to attract and retain health workers? What dimensions of organizational culture matter for this?
Thank you for this question. And I think I approach it a little bit maybe from international perspective and then just combine something from my own country and the Nordic countries. I would say in general that quality healthcare is dependent very much on effective organizational factors, which include that interdisciplinary teamwork, but also a supportive culture and this good leadership. And that is required to enhance really the development of healthy work environments, which I like to talk about. So it's no matter where the setting is, some of the elements are shared in all the care settings. The impact of leadership in healthcare has impact on patient outcomes and moreover, well-being at work, job satisfaction and staff retention. And therefore, leaders should be recognized leadership as a major indicator for developing qualitative organization culture. And it is indispensable in work environments that retain an empowered and motivated workforce. And we know that leadership styles can improve, for example, the job satisfaction in nursing, organizational commitment, intent to stay in their position, but also simultaneously for example, reduced stress and emotional exhaustion. So I would say investing and developing multidisciplinary research leadership is one key. However, we do need to look at this from the individual point of view. So those primary healthcare professionals who work in the primary healthcare field, often in these interprofessional care teams. And I would say that functioning and good interprofessional collaboration is very much beneficial for the patient and the staff members, but the whole organization. And this brings me to the need to understand what are the challenges now. So we can look at it from the different perspectives. And first, if we look at the research, so do we know factors which have negative impact on well-being? And those, just to give a few examples, high workload, low staffing levels, ethical problems, non-supportive professional community, communication problems, lack of control on their own work. However, that's information we need to understand what we want to change. We should also look at the individual and team factors. So what do we know is that both the interprofessional collaboration and work-related empowerment are very much associated with quality of care, but also the job satisfaction and well-being of staff. Recently in Finland, so I had the privilege to lead a research project where we looked into work-related empowerment and interprofessional collaboration in the cancer care setting, and we did find that work-related empowerment and the interprofessional collaboration had very strong correlation, and this means that work-related empowerment can also be promoted through teamwork training and supportive management. The work-related empowerment itself, it refers to an individual having experience of carrying out tasks related to his or her own work. There is a paper by Linsen in which they propose that improving work control, emphasizing quality, cohesion, communication, and values may improve general clinician satisfaction, stress, and retention. Therefore, the second key is to invest on developing interprofessional collaboration and enhance work-related empowerment. And the last one, I would say, is the investment on work environments and healthy work environments. There is an example on one study where elements of healthy work environment were explored in primary care nurses. And they found that particularly true collaboration is important for successful collaboration between members of the interprofessional primary healthcare teams. And this in then turn reduces primary care nurses' burnout and increase their experience of meaningful recognition. They used in this study a framework called the Standards of Healthy Work Environment. Originally it was developed by American Association of Critical Care Nurses. However, this is a great tool to be used also outside of that specific care context. And I would say also in with different professionals as well, and in the interprofessional work environment. So there is a link on the chat box, and please take a look if you are interested to learn more about that. Thank you.
As you were speaking, my colleagues in the studio were nodding very much, and I think we will come back to some of these issues later on, especially the healthy work environment. But let me come back to you, Virpi, for one moment. You mentioned leadership several times at the beginning of your intervention. And in fact, our last talk show with our regional director, Dr. Hans Kluge, was on leadership in primary healthcare. It was really a fascinating discussion where we talked about what type of leadership works for primary healthcare, right? And in that talk show, we emphasized very much that top-down approaches are unlikely to work because we need national frameworks, but we need local implementation, tailoring implementation to the particular issues and problems of each community and each region. And because of that, we need distributed leadership, we need autonomy at the facility level, and we need to invest in these and acknowledge that these are particular areas. I am sorry for digressing a little bit. I want to come back to you with that introduction. Say a little bit more about what's important for multidisciplinary leadership. And in particular, how do you see the role of nurses in this? Today, we were so impressed with the nurse we met at the Primary Healthcare Center, and we saw some real leadership. What are your thoughts on this? Because if we want multidisciplinary work, we want multidisciplinary teamwork, we need multidisciplinary leadership, and we need multidisciplinary governance. How to get that? Are we getting there?
I think it's interesting and very important question, and you actually answered almost the same way I would answer. So I would say that first of all we need to look at the leadership also from the interdisciplinary view. So we do need to see leadership as also a model for the whole community and the whole work environment. So if we have a well-functioning interdisciplinary leadership, so that also reflects on the teams working in that particular unit. So, but I think in a very practical approach, I would say that we need to get and bring people together. We need to bring the leaders, but we also need to bring all the healthcare professionals working in different roles and to work together and think about how to best provide the services we are aiming to or we need to do in this particular, for example, area. So we can develop together the way how we work.
Let's now with that, and apologies again that in the question I answered some of it myself. I find this topic very interesting. Antonia, you're the best position to talk about a happy work organization and organizational culture. Tell us a little bit about your center. What have you done to enhance the organizational culture and make your center an attractive place to work at?
Thank you very much. I will present with few words our community health center, Ljubljana, which is the largest in Slovenia with 16 sites. We have more than 1,600 employees in 24 clinical areas. Our capitation is about 400,000 patients, and we have about 3 million patient contacts per year. There are differences between the sites because they are in different environments, but we respect and encourage diversity. Few examples of initiatives. Yes, it's important for young colleagues to adapt their working hours to their families, so we offer flexible working hours. And due to the shortage of physicians, we have introduced chronic patient clinics where registered nurses check up chronic patients according to predefined protocols and contact a physician only if there are deviations. We identified a group of 30 young, enthusiastic colleagues and prepared a workshop for them on how to be visible and how to lead. This is also the group of young employees that we ask what is important to them so that they can give us guidance on what to do. We enable research work and academic development. It's very important. It has to be on the primary care. Young people present their research at international congresses, and we also involve young researchers from other parts of Slovenia, other health centers, because networking is important. We are implementing patient empowerment through peer support as part of our expansion of integrated care. It means expanding the team and engaging the most important member, the patients, for better health outcomes. We have additional example of initiative, but I think that these are the most important. I give the floor other members of this panel. Thank you.
Those are very interesting initiatives, and I'll just pick out the one you mentioned on research, because you can't imagine how often we hear this as one of the reasons for leaving primary healthcare and going on to a specialization is the lack of opportunities to grow academically. So I think this is very important, and it not just creates an interesting work environment and diversity of work functions and tasks, but it also enhances the prestige of primary healthcare. And in this sense, it's a very important tool, and we need to be mindful to create these kind of research opportunities as well. Thomas, I'd like to come back to what Virpi mentioned about a healthy work environment. And there has been a lot of attention paid to this during the pandemic, right? We see some burnout among health workers. What do we know about this issue, and what are WHO's recommendations to improve the health and well-being of our health workers?
Indeed, Melita. I think the COVID pandemic has been a turning point in the way we see the health and well-being of the health workforce. Before, I think it was pretty much neglected, and I think we have to recognize that. After that, we have seen during the COVID pandemic how health and care workers have been exposed to a higher risk of COVID infections, deaths, and also to psychological burnout, depression, stress, and even, in many cases, even suicide. So I think we have to really recognize the big effort that the health workforce and care workforce have done during the pandemic, and now it's time to really reflect on that and look forward and put the health and well-being of the health workforce at the central stage when we plan our policies for the way forward. Last year, 2021, was the International Year of Health and Care Workers declared by WHO. And the main theme was invest and protect the health and care workforce. So we were bringing to the central stage protecting the health and care workforce. WHO is working on the Global Compact to protect health workers, to make sure that they work under the right working conditions, and also to protect their rights. So that's part of the WHO work that WHO is working. In addition, you were asked, just to bring one example, I think Ireland was a very good example on how during the pandemic really take care of the health and care workers. First, monitoring what was the situation. I think this is important. What is not measured, it doesn't exist. So first, monitoring. Second, training health and care workers to be able to protect themselves during the pandemic. And third, enabling different platforms, websites, call centers, personal assistant for psychological support during the pandemic and after that. So I think that's a good example that we have a vignette. Primary Healthcare Center GDO in Almaty has a very good vignette, so I encourage everyone to go through it and learn from the example of Ireland.
And to wrap this discussion of our second round, Natasha, thank you for your patience. You were nodding enthusiastically as the different colleagues were speaking. Please feel free to reflect on any of the comments, and I know some of them resurfaced in our discussion earlier today. But also, one of the issues with the organizational culture is we're talking about all these exciting initiatives in the context of a very heavy workload on primary healthcare. And this workload is just increasing. What can we do to address that and manage that?
Thank you, Melita, and great interventions by Virpi, Antonia, and Thomas, of course. So I think basically we're talking about young people, and the first and most important thing is to understand their values. And we know that the pandemic has really changed people's perspectives, but including those of young people. And the work-life balance has become a very, very important and critical value. So unless we are able to build our primary healthcare services in a way that recognizes that our health workforce, the health workforce of the future, has a certain value set, and we need therefore to enable them to keep their personal, family and professional life in balance, we will not be attractive. So I think this is the very first message I would say. And then about workload. Of course, we need to be really looking at the future. We need to be understanding what the demographic needs are going to be. We need to understand why the workload is increasing, how the workload is increasing. And I get very worried when the conversation about putting primary healthcare at the center of our health system just becomes a matter of shifting additional tasks onto an already overstretched primary healthcare workforce. This is something that worries me very much. So what do we need to do? We need to ensure that we really build the workforce in a way that there are the skills and the competencies in the team to meet the needs that they are encountering. So for example, Today, almost half of the time of a primary healthcare professional could be spent on matters that are somehow related to mental health. So clearly we need to ensure that psychologists, social workers, occupational therapists are part of the primary healthcare workforce so that the workload can be distributed properly. Secondly, we need to explore also the nature in which hospitals can change to provide backup and support virtually, reaching out and taking on some of the more complex and challenging cases, even to support the primary healthcare workforce. And then finally, and this one intrigues me very much, and I was really delighted to hear the example from Slovenia that Antonia shared with us. Patients want to engage more with their own health. Patients are able to do more. Let us equip and empower them. Today, for example, when it comes to banking, to travel, to retail, there is so much more that the consumer does. We have many patients, for example, with chronic diseases who really know and understand their illness well. Can we, in a way, engage patients and give them the tools to be able to do more themselves? And finally, another point. We were speaking about paperwork before, but I am also concerned that sometimes digitalization takes place not sufficiently in collaboration with the users, the patients and the workforce. And we need to make sure that digitalization processes do not add additional burden to the healthcare workforce, but they actually gift time to the health workforce. I think there are many creative ways in which we can recognize that there is a burden that is due to increased need, to increased awareness, and we need to find ways to manage this better.
I am sure that everybody's nodding, especially at your last statement, as many of us have experiences with this. This is a very good way to close our second round, and I have 4 takeaway messages. Critical to improve organizational culture is putting in place multidisciplinary leadership to provide autonomy and space for innovation for young health workers, but also for everybody in that, and then adopt it gradually in teamwork. Create a healthy workspace, and we increasingly know more and more about this, the importance of this. And finally, again, invest in primary healthcare to ensure that we have the tools to respond to the demand and the volume. With that, I'd like to go to our third round, where I would like to talk about reimagining health worker education. So we will talk a little bit about education. And let us motivate this round again with the voice of our young health professionals.
Our training at med school at pregrad level do not prepare us well for a holistic approach. We learn in syllabus about diagnosis and disease, and I think we need more interprofessional training with nurses, social workers, pharmacists, psychologists, and the other professionals. Also, we need more training in the community where disease starts, and not only in hospitals where we deal with the consequences.
So much of our work is non-clinical, and we use soft skills like communication, cultural sensitivity, and teamwork. Whilst our training is about hard skills like physiology, diagnostics, and diseases.
To be well equipped for the complex environment in primary healthcare, our training should be more pragmatic, and practice should take place in primary healthcare and in general practice, and not only in hospitals with specialists.
I believe these words are eye-opening, and our young professionals are very critical of the education they received. Surely we can do better to provide fit-for-purpose health education. Natasha, let me come to you and ask you perhaps a provocative question. Should we think about an evolution or revolution as we think about changing education of health workers?
So perhaps you may not be very happy because I'm not going to be very optimistic, but you have asked me for a real assessment here. I think we are still training our future generation to work in the health care systems of the last century. Clearly, the needs have changed, and I think the young people said it. The curriculum at the moment is not really taking into account the skills and competencies that then we expect people to have as soon as they enter the workplace. Now, on a positive note, I know that many medical schools, many nursing schools are seeking to find ways to embrace this change. But it's still not a sea change, and we need to bring about a sea change, particularly, for example, in the way at the moment we still have in many educational establishments too much siloed solo professional education, and then we expect people really to work as multidisciplinary teams. Again, I think there are promising initiatives, but we really need to think critically about how we scale these up, how we really change at the core the way in which we are preparing. I don't even use the word training. I use the word really preparing, skilling and equipping. And this links back to what Thomas was talking earlier also about the mental health and well-being, about the stress and the burnout. Sometimes this arises because of a gap between the role expectations and the skills and competencies that a person feels that they actually have.
Yeah, indeed, very much so. So it was a provocative question, right, Natasha? And you gave a provocative answer. So let's kick the ball to Thomas. What does WHO recommend to countries? Let's imagine we inspired a policymaker today to take charge of their education of health workers for primary healthcare. What should they do? What should be their priority areas to address?
I think we need to rethink what we teach and how we do it. Because as Natasha said, we are still kind of educating for the past century. And I think we need to look at the future, think what the health needs will be in the future, and then how we are going to reorganize health services and have the right health and care workforce ready for provide services in 10, 15 years. And to do that, we need to start now. So I think Natasha already mentioned the review of the curriculum. Clearly, we need to bring the competencies that were mentioned in the videos, communication, putting patients at the center, digital skills, all that has to be incorporated in the curriculums. That's one. Second, interprofessional education, and that's a clear recommendation by WHO. If we are talking about teamwork, multidisciplinary work in primary health care, we need to bring all that in the education sector. So we start bringing different types of health professionals together during the education phase, so that it will be natural to work together in a team later on. Then third, I think we need continuing professional development. We already have a huge health workforce, and we need to start now bringing all these new skills and competencies for that health workforce. So building continuous professional development is a key element. And then I would like to mention also the importance of family medicine specialization in certain contexts. So I think there is an opportunity to really bring a strong and with quality family specialization in certain countries, making sure that they get the right knowledge and skills so that we can really transform the primary health care of the future and be ready for the primary health care of the future.
Virpi, let's come to you because you're the one who is in a university setting. Are you see these changes happening? Is your university a pioneer in these areas? What are you doing, and what do you think you need to be doing in the future for the coming decade?
Yeah, thank you. Because I think in many ways, education is one of the solutions how we transform the future healthcare and the primary healthcare overall. I think the education system and the way we think people learn in healthcare is undergoing quite a lot of changes. Our priority is still on training those highly qualified healthcare personnel. However, today it's even more relevant than ever. And we have a great body of evidence how, for instance, in nursing education is in fact related to clinical outcomes, for instance. So we know that the higher the education of the nursing staff is, better are the clinical outcomes, for example, less comorbidities, less readmissions, and so on. So, for example, Professor Linda Aiken and her colleagues has done a lot of work in the field. During the last couple of years, so we have been seeing a big leap from the traditional classroom approach to world of online learning. This happened in my university. This has happened across Europe. I'm sure that we can all see the benefits of it. We also have seen those challenges, and I think, in my opinion, now it's the time to learn. So let's take those good sides of it and then think about what did we do previously, and then put those together and create a new, better approach maybe to healthcare education. I think many of us share the vision of some worries as well, so that there are lack of people applying to undergraduate programs and also in specialization program, for example, in general medicine and primary care. And I think that requires us to enhance the image of health care in general. Another example is those worries which have been expressed on training opportunities in the universities, and students may be afraid of seeing the patients. They may have lack of communication skills and so on. And because we live in a digitalized era, so the communication skills, how we work together in the digitalized world, is more important than ever. We need to prepare our students as well, changing from the information sharing for a coaching role, for instance. We use a lot of different kind of learning and teaching technology nowadays. So if you ask from the teacher, blended learning, flipped classroom, with the use of peer learning, mentoring, virtual reality, gaming, simulation, pedagogy, you can hear all of these. But it's pretty much on combining different approaches to serve the needs of different learners, because we know better and better how people learn in a different ways. What we have learned, which will change the way we do, is that you can also not only do the theoretical training or theoretical education in face-to-face live situation. You can also do that live online and use some of the digital tools we have nowadays. And lastly, I would like to just share one of my dreams, because we have these digitalized patient care pathways. So I would like to see our professionals working and our nurses working in the primary healthcare field to go working hand in hand, the patients in the digital care pathway, to see what their needs are, in what state, and how we could work better together, and what we need to change in education and in the work setting.
Well, to me, that sounds very inspiring. And if I was to choose my profession today, I might seriously consider becoming a health worker in a primary healthcare setting, a family doctor. So that sounds very interesting. But reflecting back to the video, one of the demands of our young health workers was to have problem-based practice in real primary healthcare setting. Antonia, your center does provide this type of practice as well as continuing medical education. What lessons have you learned in this process?
Thank you. I have to say that we teach patients and professionals, but now I'll talk about professional education. When we teach students, everyone has their own mentor when they practice, and faculty curriculum is followed. But when we ask our young colleagues, we find that they don't want passively listening to lectures. They want to learn actively in the environment in which they work. So we teach cool teams in small groups and use various modern approaches. One is teaching through simulation, using realistic dolls or using a role play in a real environment. Different modules are prepared, as is, for example, a team approach to medical procedures, palliative care, emergency situations, communication skills, childbirth in the field, and so on. We use augmented reality, which is designed to teach extremely rare but dangerous situations, for example, anaphylactic shock, where a team, if not trained, will experience the death of a patient. Once a year, we organize a competition between medical teams from different parts of Slovenia on how to solve unpredictable or life-threatening situations using simulation. At the end, of course, we announce the winner. In our health center, we also enable teams from other health centers in Slovenia to learn with the same modern equipment and modules, or we travel with the mobile unit of the simulation center to their location to bring teams together. But the content of our education responds to patient needs and are prepared for patients. Thank you.
These are very interesting ideas, and both between you, Thomas, Virpi, and Antonia, I hope education of health workers in the future will be like this everywhere. And we, from our side in WHO, we will make sure to invest in this area and distribute and spread and share knowledge and good experiences. And now, to close our plenary discussion, I'd like to ask you, Natasha, one reflection. Some of the topics we talked about are not new. How long have we been talking about prestige, right? How long have we been talking about improving organizational culture? How long have we been talking about the burden on health workers? How long have we been talking about reimagining health worker education? Are you optimistic about this coming decade? Will things be different, or will we sit here 10 years from now having this talk show again? What are your views?
That's a tough one, Melita. So, you know that by nature I'm an optimistic person, and I'm actually optimistic about the vision and about the ambition. We see in a number of countries at the moment that there is a vision and an ambition. But I'm less optimistic when I start seeing then the hard facts, the reality, the investment that is going, for example, into primary healthcare infrastructure. As we review the plans that countries are submitting, we still see that most of them are investing far more in the hospitals. I'd really like to get my hands on data about the proportion of medical and nursing graduates that are actually ending up in primary care, unless we really scale up and strengthen the primary healthcare workforce, unless we really bring the teams in, unless we make sure that the people who are working in those centers have the access to the digital technologies, to the technologies they need, to the medicines, I very much fear that we will end up as we did in 2018, when people gathered here in this country, in Kazakhstan, to reflect on what had been achieved since the vision in Almaty 1978. There was, of course, a lot of good that had been achieved, but there was also a sense of disappointment that there was still so much that hadn't been achieved. If we don't want to be here again in 30, 40 years' time, still lamenting, I think the key is that we cannot expect our health systems to be reoriented towards a primary healthcare approach if we place all of the responsibility on primary healthcare. It needs a fundamental whole system change and engagement. And this is why, for example, last week with Thomas, we were having a meeting with experts from hospitals, because unless we realize that the adaptation to go towards a primary healthcare oriented health system, as is what everyone wants to achieve for reasons of access, of quality, of well-being, of efficiency, of sustainability, then this really requires us to bring the whole of the system behind this vision. And I think that's what we need to work towards next.
That's very important. And I think we can promise our viewers that from our end as WHO, we will not let our guard down. We will continuously push for enhanced investments in primary healthcare to make sure that the issue of prestige is put on the table. We cannot separate the issue of primary healthcare from the health workforce, and this is why we're working so closely together. And we hope to share more and more success stories to inspire, but not let our guard down and be overly optimistic. And with that, I would like to thank our panelists for taking their time to join us for this very interesting conversation today. And now we would like to hear from you, dear viewers. I know that there are many young professionals among you as well, and maybe our original young professionals who were brave to participate with us in June. And we now invite you to 2 breakout sessions, one of them in English language and one of them in Russian language. You can join whichever you choose. My colleagues are posting the link into the chat. Please join. And we're going to leave this window open as well so that you can get in touch with us if you have trouble joining. Thank you very much for being with us today, for participating, and see you next time.